Hello, my name's Professor John Seymour from Melbourne, Australia, and I'm here at the 18th CLL workshop with Professor Richard Rosenquist from the Karolinska Institute. And we've just come from the sessions where we're exploring some new methodologies and new predictors. Richard, you talked about baseline and pre-treatment factors, and we're in an era where things are changing, and what used to be predictive may no longer be in the novel therapy era. What do you think we should be doing for our patients now, and what do you think are the emerging elements that may perhaps have a role in the future?
Yeah, so I really think we should continue to follow the iwCLL guidelines and do the FISH, the genomic aberrations with FISH, and also TP53 screening. Also, I mean, I'm a strong believer in IDH mutation status for several reasons, so I think this should be included. But as you alluded to, of course, the novel therapies, it seemed to that IDH mutation status and some of the genomic aberrations does not have the same predictive role. Mm-hmm. We will see what will happen in the future.
Yes, so certainly once a patient has commenced treatment, now that IGH mutational status does identify and predict for who may need treatment. Yes. But once you have commenced treatment, in the novel agent era, the prognostic value of that and deletion 11q appears to be dramatically reduced. P53 dysfunction is maintaining its relevance.
Indeed, so I think we will continue. You asked for the future, and I think that TP53 it will remain, both looking at the genomic aberrations and TP53 mutation screening. Another issue that is discussed and was also brought up this morning is the presence of low clones, microclones with TP53 aberrations, and there have been some, the majority of studies have shown rather clear results that they have clinical impact, and they seem to have similar worse prognosis as...
So these are small clones below the 10% level that is traditionally identified with Sanger sequencing, but smaller levels that newer technologies can identify.
Yes, good that you pointed out. I mean, with the new technologies, next generation sequencing, we can sort of capture smaller clones below the 10% cutoff, which usually is the cutoff for Sanger sequencing. Mm-hmm. And when you do this, it seems like just having a small clone of a few percent of cells with the TP53 aberration seem to infer a similar poor prognosis as if you have a Sanger-detected TP53 aberration. But there have been some, discrepancies also in the results presented here. In order to, at least from a technical point of view, to harmonize this, we have actually started within ERIC, the European Research Initiative on CLL, a multi-center study where we address this question: can we, in a uniform way, assess mutations that are below 10%, that we get the same results independent of where the test has been performed? Because it is a little bit difficult. Above 10%, I'm sure that most labs will detect it, but below it can be discrepancies depending on the technique that the institute is using.
Yes, and we're beginning to see some studies. Catherine Wu is published in Nature, and Dan Landau will be presenting later in the meeting around serially tracking clonal dynamics. And in a research setting at the moment, but I think it will be fascinating to be able to follow and look at the differential outgrowth or sensitivity of these various clones to the novel therapies, whether that has the potential to, earlier in the disease course, identify if there is emerging resistance. I think that will be fascinating.
I agree with you, and I think that's the way forward. We have to do longitudinal testing of the patients, and already now, of course, when you give some of the novel therapies, we do some genetic testing for BTK, PCL-gamma2, and BCL2, and then we are more and more taking ultra-sensitive technologies like digital PCR in order to track small clones. But I really I share your view that we probably need to do this, look at the clonal development or subclonal development over time in order to use or ultra-sensitive technologies to see emerging bad clones coming up.
One of the things that I have an interest in, and I'd like your views, is previous adverse prognostic factors, really other than TP53 dysfunction and probably complex karyotype, are no longer predictive of outcome in the novel therapy era. But we're not yet at the point of identifying which are the predictors that identify the heterogeneity. Is it that, for example, Notch is emerging as probably an adverse predictor for venetoclax treatment? Will there be some subsets, for example, SF3B1 or Notch, that may do better with one novel therapy than another? I think that's a challenge for us too, because there will be biologic predictors in the novel therapy era, but we don't yet know what they are. Do you have any thoughts around, will they be molecular predictors, and which you have an interest in exploring as potential predictors?
So I think that what we are trying to do at European level, and not, I mean, within ERIC, we try to collect large cohorts to address such questions. For instance, we have now a large cohort of almost 5,000 patients where we looked at the 10 novel genes to see which ones are the really strong ones, and what is the predictive capacity for each of the gene and combinations of genes, etc.
And you've got the ability to look at that by treatment delivered, because of course it may differ if you're receiving a BTK inhibitor or venetoclax.
So this is a retrospective cohort, and I mean we will only use for time to first treatment because that's the only thing we can reliably assess. But I think what you're saying will be very important, and also it will be a little bit problematic because we have many different studies, many different agents. There will be probably also different sequencing of the therapies, and it will be important to collect samples in a meaningful way so we can address these questions. And usually you need to have rather large collections, and just thinking of the potential novel markers like SF3B1, Notch1, etc., and the different type of available therapies, we will have some work to do to be able to assess the strength in the new era.
We'll need very large numbers because some of these, for example, SF3B1 are at the 3, 4, 5% level, so you need large populations. Finally, an emerging theme to me here at this meeting was that MRD, so deep remissions, currently at the 10 to the minus 4 level, are very consistently being used as a short-term measure of efficacy, and may be able to be used to pick a winner amongst the many novel combinations that are being explored. But also emerging information that perhaps, and this is not yet clinically applicable, but perhaps deeper remissions may be reliably measured and may identify subsets who have very favourable long-term outcomes. So your thoughts, are we moving into an MRD-guided treatment era, and do we have the potential to go deeper than 10 to the minus 4 consistently and reliably?
I think Andy Ralston did a great job this morning explaining where we are, the current situation, and he also stressed that we should keep the 10 to the minus 4 level and not change the cutoff so rapidly, because since many studies are designed in a certain way, it may be difficult if we start changing the levels. Having said that, I think that I've also been involved in diagnostics of CML for many years, and of course there we report every time for BCR-ABL which MRD level the patient has. And I think that probably we will come to a similar scenario where we have different type of MRD levels is indicated in the report, and I think that considering the long progression-free survival that we see with the novel therapies, we have to have another, we have to measure it in another way, and I think MRD seems to be the way forward in that aspect.
Yeah. So to wrap things up, it's exciting times here in the CLL world. The current iwCLL guidelines remain what we should be working with in our clinical practice, but in a research and in a forward-looking sense, novel biologic predictors are an exciting theme, and deep levels of remission are regularly achievable and have the potential to guide our treatment choices and our patient management into the future. Thank you.